Can I introduce myself? My name is Dr. Mike Durkin, and for the last decade or so, I've been involved with supporting patient safety improvement in my own country, the UK, but also in many of the countries who are represented in the room, and also countries who are represented in this report. Can I first of all ask you to make sure you take this away with you? There's lots of facts in there, but also, and more importantly, there's lots of references to future work that is going to be important. I'd like to thank the Qatar Foundation for supporting this work and giving us the opportunity to share with you a policy briefing on safety and maternity services internationally, but also to thank the Leading Health Systems Network, which is a network of interested hospitals and systems from around the world who have come together to support this report, but many other of the reports that you've had access to over the last 2 days. We have 45 minutes for this session, and we're going to really want to hear from you as much as we hear from our experts. So I've asked our experts to be fairly brief in their conversations with us about their particular topics so that we have time at the end for a good Q&A session. Maternity safety is a key element for every country in the world. You've read in some of our data that over 300,000 women die a year across our world in all our countries. There is no country that is immune from harm in maternity, whether that's death or, as often is the case, morbidity as well to the mother. We also have an increasing number of child injuries, neonatal injuries, as well as a consequence of birth in our countries. So this is not something that is just an issue for the developing world. It's a huge issue for every country in the world. I'd like to start our questions, therefore, by introducing our panel. And I'd first like to introduce Gianluca Fontana, who is a Senior Policy Fellow and Director of Operations at the Center of Health Policy at Imperial College. We have Dr. Anupam Sibal, who is representing as the Group Medical Director of Apollo Hospitals in India. We have Dr. Marina Darafiledze, who was from Georgia and who is representing there as head of their healthcare department of Ministry of Internally Displaced Persons. And we have Professor Tony Kelly, who is the National Clinical Director for maternal and neonatal health safety improvement in the UK. I'd like to start with Gianluca, who is going to give us a background on the role of the LHSN, in particular, the work that they've produced for us on maternity safety. Thank you, Gianluca.
Thank you very much, Mike, and thank you to all of you for being here. LHSN, the Leading Health Systems Network, is a global community of health systems and healthcare organizations that collaborate, compare performance, and try to improve together. We started the network now almost 10 years ago with an early focus on disease pathways. So we started from looking at the old pathway of diseases like diabetes, stroke, and CHD. And for the past 4 years now, the network has focused almost exclusively on patient safety. So we've done a report and a collaborative on incident reporting and on learning in patient safety. We have done the work on maternity, and we've also collaborated on a report on antimicrobial resistance that Dr. Sally Davies mentioned yesterday. It's a fantastic group of organizations, and I thank Apollo for being part of it and having been part of it for a very long time. I see some of the other members in the room today. We have 21 organizations across 14 countries. Subgroups then come together to collaborate on different topics. And for this report in particular, we had 8 members that really went through quite a burdensome data collection effort. Hopefully with a reward at the end in terms of lessons learned and in terms of collaboration and sharing with other members. So just a brief note on how we approached the issue, We looked at the context of maternity services in each country. We conducted a survey on safety culture based on the validated safety attitudes questionnaire, and then we looked at the outcomes for patient safety in maternity. And the main finding, I would say, and we can talk more about it, but the variation that we have seen across our group, which is confirmed by numbers, for example, from the OECD, is staggering. And it's interesting because there's not as much variation in terms of culture, actually, and some variation in terms of the context and how services are delivered, but certainly huge variations in terms of outcomes. As always, international comparisons probably raise more questions than they answer, but that's part of the process, and that's part of what we find helpful is to go deeper and ask more questions. But hopefully Anupam will illuminate us on the experience being a member in the network as well.
Okay, thanks, Gianluca. I do have some questions for the panel, but I'll come back to one later. So Anupam, thank you. If you could describe your work.
Thank you so much. I'd like to thank Wish, Mike, the team for this opportunity. It's been a great learning experience for us being a part of LHSN over the years, and Wish has provided us with a wonderful opportunity to learn. So greetings from 1.3 billion people in India, and I'm just highlighting that because we produce 25 million babies every year, more than the population of Australia. So every day more than 68,000 babies are born in India. That's every minute 47 babies are born. So in the 5 minutes that Mike has given me, 235 babies would have been born in India. So when you're looking at such massive numbers, you obviously have huge challenges, and therefore the solutions really have to be out of the box. Just to give you a sense of where we are today, and for that I must take you back. So if we go back to, say, 1998, the maternal mortality rate was 430. As of 2016, it had dropped to 107. If you look at the number of institutional deliveries, they've gone up from 18% to 79%. There are some states in India, India has 29 states, that have made remarkable progress, and Kerala is one such state. It is the best performing state in India, and there the MMR in 2013 was 61, and in 4 years it's come down to 46, and they're bringing it down every year. So what has changed? Well, a few initiatives. One has been that the different state governments have started some schemes. The schemes are for getting monetary compensation for registering as a pregnant lady. You get an X amount of money when you complete the antenatal checks, when you have your tetanus vaccination, if you have an institutional delivery, and then when the baby is born, if the baby completes all the checkups and has vaccination, there's an X amount of money that's given. So that's been very positive, and that's really shown traction. The other thing that we have to realize is that it is about empowerment of women. India became independent in 1947, and in 1951, the female literacy rate was 8%. 8%. That is now 68%. The other change that we've seen in society is that the older a woman is when she gets married, that in itself has an impact on her health, and that percentage has gone down from 47% of women getting married before the age of 18 to 27%. And the final realization that has dawned upon everyone is that if we are to overcome the challenges we have to look at a public-private partnership, because 70% of healthcare in India is private. To give you one simple example, on the 9th of every month, any woman can walk into any facility and get free antenatal health checks. So all the private hospitals are part of this initiative that was launched about 18 months ago. In Kerala, where there's been a lot of success, what have they done differently? I think standardization has been the key. Standardization of the systems, the processes, the infrastructure, equipment, a lot of emphasis on training, putting flow diagrams everywhere in the hospital, making sure that everyone gets trained and retrained, and having disposable kits for both cesarean and for normal deliveries. And I think the fact that it has 100% literacy helps. So clearly, Kerala is a shining example of how things can can move in India. The government, the Prime Minister launched last month the most ambitious health scheme in the world. And the numbers are going to be truly staggering when you hear them. The idea is to reach out to 100 million families, that's 500 million people, through an insurance scheme that was launched 6 weeks ago. And there are two pillars of this program, which is Ayushman Bharat. So there's one pillar, which is the health and wellness centers, and 150,000 of these are going to be opened. And they're going to be focusing a lot on maternal health, on infant health, on child health. And then there is the National Health Protection Scheme that is going to open up the private sector to the common man. So through this insurance program, they can come in for a lot of procedures, including deliveries, including cesarean sections. And that is being rolled out. And that is really going to enhance access like never before. Now, turning to what we do at Apollo, I'm the Group Medical Director of Apollo Hospitals. We are India's largest integrated healthcare provider. We have 69 hospitals, 9,000 beds. So in terms of maternal care, what we've done is very strict credentialing and privileging for everyone, not just doctors, but nurses, technicians. In our system, only a consultant obstetrician can deliver a baby. And every delivery is attended by a consultant pediatrician and a consultant neonatologist if we anticipate complications. We've been using technology quite effectively, and we have a network of eNICU. So what we've got is real-time data from monitors, from ventilators, from the labs, feeding into the eNICU software, which is housed on the cloud, that gives us real-time information. It has calculators that help us calculate automatically drug doses, the feeds, and so on, and also gives us a trend. And this is something that we want to take beyond the NICU and look at maternal care. We also have a network of EICUs where we provide coverage to remote hospitals, 20 of them, and we want to expand that further. And that, I think, is really going to be very helpful. We've been working very closely with the government, and just to give you an example of one scheme, it is part of the innovation showcase that you can see upstairs in the state of Andhra Pradesh. So we've linked up through telemedicine center 90 odd urban health centers. So we perform consultations and diagnostics, and we've been able to, in the last 2 years, identify 35,000 women who were high risk pregnancies, and they were then referred to appropriate centers. And the final area that we've been working very closely with the government, it's a project called Total Health, and it's something that's pretty exciting. What we are doing in several villages, and we're trying to cover a population of 70,000 in South India, we have a project called Total Health. So this is about not just physical well-being, but mental, social, economic, and in India, spiritual well-being is very important. So you've got RO plants to provide safe water. We have a nursing school. We have opportunities for women to get trained in jute and apparel production. We've developed kitchen gardens. We've got naturopathy, yoga, and so on to really develop the individual holistically. So in maternal health, what we've done is we've got nutrition centers. So women come in and we give supervised nutrition every day to pregnant ladies, and this carries on for lactating mothers and babies. And we found that with simple initiatives like giving them papaya and drumstick saplings and ensuring iron, folic acid supplementation, the hemoglobin of the pregnant ladies, when they enrolled, went up from 10.5 to 13.2 at the time of delivery. Now, this is a model that is scalable, it's sustainable, and it's replicable, and we're really excited about that. And as I end, I just want to quote Mahatma Gandhi. It is going to be the 150th birth anniversary next year of the father of the Indian nation, and he'd once said, "A man can never be a woman's equal in the spirit of selfless service that nature has endowed her." And in recognition of this spirit, I think it is incumbent upon all of us to bring women's health, maternal health, center stage. And a spiritual guru from India, Osho, had said, "The moment a child is born, a mother is born. She did not exist. The woman did, but the mother never did." So I think it's time we recognize that and respect and honor women by focusing on maternal health. Thank you.
Terrific. You set a very high bar there, I think, Anupam, for the rest of our speakers. So thank you, and also for the comments from the floor. So Marina, can we turn to you now, and you've made great strides in Georgia in your system, both in terms of following guidelines, in terms of trying to help support reduction in mortality and perinatal injury. Would you like to explain how you've done that? Thank you.
First of all, I would like to start that the population of Georgia, after my colleague, is only the 3.7 million, no more, and our sector also is mostly privatized. 85% of our sector belongs to private sector. So, what's regarding the maternal health, child health, that's everybody knows that UN Sustainable Development Goals bring together all over the world, all countries and communities to perform these tasks, and the UN Sustainable Goals are also the integral part of the Georgian government's internal priorities and action plans. That's maternal and child health is one of the 10 priorities of our country. It's usual thing, I think, because if we consider the recent statistical and epidemiological data, despite that we achieved the MDG goals regarding the under 5 years mortality, baby mortality, so unfortunately, regarding the maternal mortality, we have that's a different picture. According to the MMIG data, in 2015, we had the rate of maternal mortality 36 per 100,000. And in-depth analysis of the cases has shown that 60% of these cases we were able to avoid, unfortunately. So that's why the Georgian government's priority became that this field, maternal and child health, and in the previous years we elaborated a special strategy in this direction, maternal and newborn health and reproductive health. And main direction of this is to avoid the all avoidable deaths of maternal and the stillbirths or the under 5 mortality deaths. So that's in 2015 and 17 years has been implemented the perinatal regionalization in Georgia. This was a very successful project. That's 82 medical institutions from 106 right now are divided on 3 levels of perinatal care. Other institutions, unfortunately, could not satisfy the requirements. So that's right now we are able to send the right patient at the right time to the right institution. That's the gold rules of the safety in maternal, the child health, newborn health. Unfortunately, we have the high rate of the cesarean section of 41.3%. This is the influence of the private sector in our country, unfortunately. So under the UHC program, Universal Health Coverage, we have started the selective contracting. That's the one requirement is to decrease this number of cesarean section. And we started it in the big cities in Georgia. That's other field. Is antenatal care, of course. That's we have been elaborated new guidelines, which is in line the WHO latest guideline, and we have started under the state program to finance the 8 visits instead of 4. Also, we under our attention is the current medical education, which according to our legislations, it's not mandatory right now, but it became, we make it mandatory in frame of state programs and perinatal regionalization. And the elaboration or adaptation other guidelines and protocols such as the cesarean section or the eclampsia and so on, and the bleeding in the maternity and so on is underway. That's also the few words regarding the supplements that we finance fully covered. That's iron and folic acid for the pregnant women, and the supplement for socially vulnerable children from 6 to 24 months. And the last issue I want to say, this is a health informational system. We have the good register, birth registry, which has been launched in 2016, and we are going to strengthen this birth register, because the good data is the base of the good policies. Thank you.
Marina, thank you very much. So obviously great strides there in Georgia. We'll come back to maybe a couple of questions, if I may, later. Professor Kelly, Tony, so you've been given a role. So I know a little bit about the UK in terms of safety and safety improvement. So one of our key challenges there was responding to the place that the UK found itself in terms of stillbirth rates in particular, and also neonatal injury. Can you explain what your collaborative is, and what are the aims of the whole system approach for a population of 60 million?
Yeah, sure, thank you. So in the UK, we've got what we're describing as a once-in-a-generation opportunity to really focus on maternal and neonatal health, which was grown out of some significant reporting over the last few years, identifying some gaps in the UK compared to some of our international neighbours as to how we performed when you looked at particularly stillbirth rates, neonatal death rates and brain injury rates. And out of that has grown an English-wide programme called the Maternity Transformation Programme that brings together most of the health organisations and training organisations across the country to focus in on improvements that can be made. And within that, there is a national improvement collaborative, which I'm the clinical lead for. We have chosen to work with all maternity providers across the country, so there's 133 now, because I think a few have recently merged across England, so nowhere near the sort of size of population that we've heard about already. But when you look at our data compared to some of our neighbours, there are some discrepancies that don't make sense, considering the quality of healthcare that we deliver and the standard of living that we have in England. So there was an ambition set by our previous Secretary of State to reduce down all of those levels of harm by 50% by 2025 now, and a 20% reduction by 2020, which, to put it in context, the stillbirth rate in England last year, excuse me, was 4.2 per 1,000 total births, which is about 2,800 stillbirths a year. And we've seen an 18% reduction since 2010, which is a sizable difference. But to get to the level that we're being asked to, we have to get down to 2.5 per 1,000 by 2025, which would mean saving another 1,100 stillbirths per year. So it's a very ambitious approach. What we've done, though, which I think is unusual and in some ways unique certainly within healthcare in England and certainly within maternity, is we've been very clear about how we're going to do this. So national policy before that has taken a line which it points at things that are good and things that are not so good, and there's an expectation that we can bridge the gap. But we've very much embraced the idea within the collaborative I'm involved with that we have to build in capability within our workforce to how to do improvement work effectively, which is something that's not normally looked at so directly. We've also picked up the challenge about trying to give people much more of an articulate way of improving the quality of care that they're delivering, such that you can break this down rather than just focusing on, say, please could you try and improve the optimization of preterm babies. We're saying exactly how you can do that in the antenatal period, the intrapartum and the postpartum period, what interventions you can use, where they've been shown to be effective, and backing that up with a very effective measurement strategy. Because if you ask people to focus on a reduction in stillbirth, a jobbing midwife on a labour ward in the UK will not understand necessarily how she can make that happen. Whereas if you say to the team that are working, we want you to ensure that all babies that are potentially going to be born to mothers under 30 weeks gestation will all have received antenatal corticosteroids, and those mothers will all receive magnesium sulfate in the 48 hours prior to delivery. They can see very quickly how they are doing with regard to those sort of standards of care. So that's the way we've broken everything down. Equally, we're only really focusing on 5 main clinical areas within the collaborative at the moment, because what we want to do is to be able to aggregate the effect that any of those teams are seeing with their improvements, so we can show some shifts in national data. So we're able to sort of validate the fact that our approach, as well as the topic areas, are showing the improvements we want to see. So we're focusing on smoking cessation, so trying to improve the number of women who are smoke-free during pregnancy. The moment the national average in the UK is around 11%, and we're 13%. We're trying to get down to 11% nationally, and then below that by 2025. We're looking at the care of women who either develop or come into pregnancy suffering with diabetes. We're looking at deterioration in the peripartum period, both of mother and baby, particularly with a focus around fetal monitoring, development of sepsis in the mother, and also postpartum hemorrhage. And then we're focusing on 2 very specific neonatal interventions around looking at the management of hypoglycemia, and also looking at the optimization of the preterm baby, as I alluded to earlier. So the combination of trying to build in capability for improvement, measuring that improvement, and focusing on methodology, and then keeping the focus clinically to those 5 key areas, we think is the way that we'll start to see some significant improvements on those high levels of harm.
Great, thanks. Thank you, Tony. Thank you. So there's one of the elements that I read through the report was as Gianluca said, a variation in outcomes. There also seemed to be a marked variation in staffing, both in terms of the levels of staffing that were available for delivery suites or labour wards or hospitals, but also the mix of staffing between medics and midwives, between obstetricians and midwives. And you mentioned, Anupam, this shift of going more towards the obstetric side. I'm wondering, how does that fit with the role of the midwife in supporting care? Because I think for many countries in the world, it's often very much a midwife-led service with support from obstetricians.
So let me clarify, Mike. When I alluded to the obstetricians, that was for our system, which is 69
Sure.
hospitals, 9,000 beds.
Yeah.
And we can manage that because it's a small enough system. But when we talk about the country, it clearly is going to be about midwives, because while we might produce 60,000 doctors every year, more than anyone else in the world, but it's still not going to be enough for our population. So it really has to be about using staff appropriately based on training. But I think it's a lot about the level of training, because we all know that there is an opportunity for skilling and reskilling often. And I think that's where technology is really going to play the key determinant. And we're already seeing that, because with access to smartphones becoming so easy, a lot of these algorithms, a lot of information, a lot of updates can happen through telephony onto the person who's actually caring for the patient at the village level. I mean, just to give you one example on how technology is really going to change things, especially for us in India. So we became independent in 1947. In 1991, when the Indian economy liberalized, there were 76 million telephones in India. 76 millions. As of last week, there are 1.32 billion phones. And 460 million people routinely use the internet. So clearly this has become a great leveler, and this is what is really going to impact healthcare. And we have been behind in healthcare. Let's face it, all of us make our bookings, whether it's for travel or for cinema or for hotels, using the phone. But how many of us actually use a telephone when it comes to healthcare?
Okay. An ongoing message, I think, from WISH yesterday and today, but also from previous WISH programs and many around the world on the use of our smartphones to aid and support us. Marina, one of the elements constantly coming through is, and Anupam mentioned earlier, was the empowerment process for women in particular, and when they become mothers, in the design of services and in the support for services. How have you managed that in Georgia, involving women in the production of service delivery?
Of course,
Yeah.
of course. That's for me. For example, I'm a former OBGYN. It's of course the women are involved in this process, and our workforce among our workforce, the women are involved. That's the most of our nurses are the women. That's not the 100%, I must say. That's OBGYNs also are the mostly men's, but the part of the maybe 50% of them are the women. Women are that's powerful people became in Georgia in the nowadays. I think that's they love to work. They are more humanic persons, and they know what is the issue which is related to delivery and pregnancy and so on. They are the good persons in our field, I think.
Okay, thank you. Yeah, Anupam. Yeah.
Mike, if I might just comment on empowerment, it's a very romantic word, isn't it? Everybody uses it all the time, and we used it a lot as well. Till we started our total health project and realized it means nothing. It's just a term unless you link it with economic empowerment of women. So we realized that you could give all the information about, how to improve the family's health to women, and they would go home and try, but nobody would take them seriously. And when we started the jute and the apparel manufacturing units in the villages, and these women were guaranteed $150 a month, and when they went home, everybody listened to them. So economic empowerment is really the key.
Okay, thank you. Before we open it up for questions from the floor, Tony, we've talked about culture a lot, and I'm sure that will come through from the floor, and the different cultures that exist, particularly in the obstetric and maternity midwifery world, between different professions as well as different settings. But I'm wondering, is there one thing that you're starting to think about would be one of the biggest differences in delivering an improved system, both to reduce stillbirths, reduce neonatal injury, and improve maternal health? What would be your learning so far from the collaborative?
I think the one thing that we've found so far from the work that we've been doing is culture sits at the heart of everything. So we've just completed we've done culture surveys in 2/3 of the deliveries, the trusts across the country that deliver healthcare. So just over, I think it's 83 units have taken part so far, which has involved surveying. We've had responses from 16,000 people across the workforce, over 8,000 midwives, 5,000 doctors have responded. And what we're able to see, although you can't aggregate culture, because culture is very specific, as I'm sure you are all aware, to a particular care setting, you can see that there is a very wide variation in culture across England. Some organisations, some work settings seem to have a flourishing culture, whereas others may find it more difficult. But that's both within as well as between organisations. And the key for us has been understanding how you need to link the shifts in culture that you want to see to the improvements that you're wanting to make. So if you try and do them separately, or you try and ignore the fact that you need to move culture forward, then the improvements will not come, no matter how much capability you put in the system, and no matter how much opportunity and direction you provide. And part of that's because of the mismatch between the view of the culture that you work within, depending on who you are. So you may have a very different view of what your culture is from, say, a teamwork perspective or a safety climate perspective if you're a midwifery manager versus a midwife who works day to day in a clinical area. And until you acknowledge that and understand it, it's very difficult to move forward. So one of the things that we're trying to do is link very directly changes in the culture that you want to see with the improvements that you want to make. So by way of an example, one of the issues we know comes up repeatedly in national reporting in England is a failure to recognise deterioration in the well-being of the baby during labour. So we're very good at monitoring babies and mothers. We're very good at interpreting the monitoring that we're doing, and the monitoring that we've got is very, very sensitive to sort of early elements of fetal distress. But what we're not very good at is escalating that in real time. And sometimes that comes down to cultural barriers within and between professional teams. And so focusing your improvement in those areas by using human factors thinking and shifting towards much more open dialogue and flatter hierarchies is going to therefore improve outcomes. So I think we would start primarily in encouraging people to start by looking at their culture.
Okay, thanks, Tony. Now, Gianluca, last question for you. I think how do we translate this into a health policy scenario that requires systems and nations to pay attention to culture, particularly within this setting?
Well, I think we have great examples of doing that already. Already on the panel, I think the efforts that are going on in England and in Georgia are really really leading. And I think the other aspect with safety in maternity, as with safety more in general, is to raise its profile as part of the bigger debates that are ongoing in global health. For example, around universal health coverage, which I know is something that you've also promoted a lot internationally and with the support of the WHO. We talk a lot about access. We talk a lot about healthcare for all. We don't talk a lot about universal access to quality healthcare. And I think that bridging the gap between those two debates, obviously the safety debate is important, and we have a lot of interest, including here. But the universal health coverage debate and the link with that, I think, is critical. And too often we speak about access to healthcare in general, and access to healthcare that is not of high quality is not as helpful. So I think that linking with that will be the most important thing we can do to raise the profile internationally and national policy making.
Okay, thank you very much. Now it's over to you, and we've got time for questions and comments from the floor. I'm sure there are many in the room who have something to say, so we'd like you to hear that and have a conversation. Thank you very much. So yes, the lady in the back, if you could just identify who you are maybe, and then the question. Thank you.
Hi everybody, I'm Nahid from Iran. I am the president of Iran Scientific Midwifery Association. By improving the healthcare system and decrease the maternal and child mortality, but sometimes it leads to more intervention and unnecessary C-section happen, especially in my country, and I think in other regions is the same. And many fetal scan, I mean that in parallel to decrease the maternal mortality, the morbidity is increasing, and unnecessary intervention is also increasing, such the fetal scan and termination the pregnancy before any sign of the labor or labor pain. What suggestion do you have for a country such as Iran that the maternal mortality decrease, but intervention is very high, and also the midwives' empowerment is going to decrease because of a lot of obstetrician that every year educated and come to the health system, and the private health sector is empowered and many.
Okay, thank you. Thank you. Very good question, and a very important question at the moment, as we're starting to realize across the world that increasing section rates in particular is actually increasing maternal morbidity as well as mortality with regard to subsequent placenta accreta in particular.
I think we saw it. Sorry.
Yeah.
in the report as well in terms of the huge variation in terms of the rates of cesarean sections across our group. But I think our group can then comment.
Maybe Marina and Tony.
Thank you for your question. That's where I may say that we're neighboring countries, and that we have the same problems, the same challenges. That's I mentioned that we have the high rate of the cesarean section in the private sector, and that we have the lack of the midwives and nurses, and we have the huge amount of the doctors. The same problem. That's that I mentioned. We. To improve the quality and to reduce the number of the cesarean section, we decided to start the selective contracting. And one requirement and the agreement is that to reduce the year by year the ratio of the cesarean section. And in last year, 16 medical institutions were banned accorded because they don't satisfy these requirements. That's that we because we have the tendency of reducing the cesarean section. According to our legislations, is able, that patient is able to choose the cesarean section without that reason, medical reason, and that's it, the trigger of this. That's I know that is the human rights. In one hand, we have to protect the human rights, but in other hands, in point of view, the medical reasons, that's it's hard to answer in this question. We in perinatal regionalization, we define the number of the nurses and midwives. So the private sector is obliged to have that such kind of the amount of nurses and such kind of the amount of doctors and such kind of the amount of the midwives. I think it helps to increase, to attract this midwives and this personnel to work.
Okay, thank you.
Salary, good salary. This is the very big trigger.
Okay, thank you. Tony, any comments? The UK rate oscillates a little bit around the 20% and sometimes a little bit up in different places. Any theory there about how you can manage a reduction to a safer level?
So, I mean, I can give you a UK perspective on this, and certainly I think most countries in Western Europe particularly, my own personal view is that we need to stop a focus on reducing cesarean section rate and understand what is an appropriate cesarean section rate. One of the difficulties looking at cesarean section rates overall, you miss an opportunity to drill into what some of the variation tells you. So using Robson grouping, for instance, is a particularly good way of understanding where your biggest problems are. And one of the indicators, certainly in the UK, if you look at cesarean section rates overall, a focus on first-time mothers in spontaneous labour, or Robson Group 1, you will see big variations in that group, but that is probably the main indicator of the quality of care that you deliver in labour. And focusing on trying to bring that down, or understanding the variation and understanding how some areas or hospitals are able to have rates of 7-8% and others may be running in England at 15-16%, and trying to learn from those areas. The overall maternal choice in the UK accounts for about 4% of our cesarean sections, so if you talk to women and understand what their concerns are, it's a very small number. But women who've had one previous cesarean section and being very supportive of vaginal birth after cesarean in the second pregnancy is the place that we can make the most impact, and that involves a lot of careful concentration on what are the issues that were concerning them that may drive them towards choosing a cesarean section second time round, which then tumbles into further problems. So I think understanding the variation and learning from it is key, but breaking it down into small subgroups. And I just wanted to address the other problem you mentioned about other interventions, such as ultrasound scans, maybe, and other things driving up your intervention rates. And I think in England we've certainly learned just because you can do something doesn't mean that you should do it. And so routine third trimester growth scans don't improve quality of care in England. We've got good evidence that shows that. We need to be selective over who we screen, but we need to be consistent about where we use those tests, and then how they're interpreted and acted upon. And there is a tendency within the obstetrician ranks that sometimes we feel, well, actually we probably should intervene, rather than feeling confident that we don't need to intervene. And that's something I think we're starting to see more sight and encourage in England anyway.
Okay, thanks, Tony. We have some more questions. So first this gentleman here, and then we'll just move across to you, sir, over there. Thank you.
Good morning, Adam Cairns. I'm CEO of a number of hospitals in the Hamad Medical Corporation system, one of which is the new and fantastic, I might say, Women's Wellness and Research Centre. And we currently deliver around 17,000 births a year through that facility. In HMC, one of the additional complexities that we engage with every day is that across the corporation, we have, at last count, I think 163 different nationalities who all come together to make healthcare work. My question really is about culture, and I'm just wondering whether the panel has any insights into the role which predisposing national cultures might have in relation to patient safety in the field.
Okay, so I'd like to talk for about 4 hours on that particular subject, but I'll ask Anupam to sort of consider it first, because I know it's dear to his heart too.
That's a fantastic question, and we've been running hospitals in different parts of the world, and while in India the workforce is largely Indian, of course we do cater to patients of different nationalities. In other countries where the workforce comes from different nationalities, that is really a huge challenge. What is the culture of the organization? What was the culture with which that training took place in the host country? And what is the culture in terms of patient safety for the individuals depending on nationality? Really tricky area, and I think when one is running a facility, one really has to make it very clear to everyone, whether it's patients or whether it's every member of staff, on what the culture and what the organization stands for. It's easier said than done. There are lots of variations, and sometimes you will have situations where a suggestion is made on something that really is counterintuitive to what patient safety would desire, but it's so deeply ingrained in the culture that one would really have to have an open mind and sort of look at it from another person's perspective, because it's been there for decades, really. So a tricky question really to answer, but I think it's important really to stick with what the organization stands for and get everybody to slowly come around to that viewpoint.
And I think for me that question goes to the heart of why we come together in meetings such as this, in fora around the world, to learn together to create and support each other on that culture journey and that culture shift, because that for me is the end goal. And as Gianluca was saying, to reach a state where we see universal health coverage as a coverage not just for health services, but for the quality of care that we offer our patients and our support. I'll come back to you, Tony. Can we just have the next question, please, and then we'll come back. We'll keep.
It's Dr. Rafai, Medical Director of the Women's Wellness and Research Center in Doha, a colleague of Adam, who just spoke before me. I believe that there's a major contributor to the increase in C-section rates, and that is the culture of fear and the practice of defensive medicine. And there's a great contribution to that from the media side. So what's your reflections on this?
Okay, thank you. Another powerful question. Tony, you were bursting to get in that last one.
It feels like a hospital pass.
Yeah.
So we spend at the moment in England, we spend £800 on litigation costs per delivery in our country at the moment. So our bill is enormous and is getting larger and larger because of the larger payouts, particularly that we are giving for the lifelong care of babies who are born with significant brain injury, particularly cerebral palsy. But interestingly, I think in England we're embracing the fact that we need to be continuing to focus on the highest quality care and experience of care for the women and families that we look after, rather than going down the line of practicing defensive medicine. And the work IHI have done in Brazil over the last 5 years, where their caesarean section rate in the private hospitals was nearly 90%, and they've taken that down by focusing on improvement and doing multi-professional work in that environment to try and bring those caesarean section rates down. So I think it's about supporting the culture that you're working within, supporting the whole multi-professional team. And going back to the point that was made earlier, for me it's about setting an organisational charter, so what you are all there for, so you can support each other in the environments that you find yourselves. So we've moved from when I started in obstetrics in England in the mid-90s, that the obstetrician would arrive like the cavalry when the problem had already occurred, and we would come in and clean up, and that often involved doing caesarean sections and various other things. Now in the organisations that work well, we're there as part of the team predicting the problems that might be occurring and avoiding them from happening in the first place. And so I think working together in that way allows you to be able to both predict and manage more actively, and therefore you do feel more supported, and therefore that the practice of defensive medicine can go away. But it's an inevitability, sadly, I think, that the costs of providing healthcare go up from a litigation point of view. Yeah, I don't know if that answers the question directly for you, but it certainly would be the view I would take.
Okay, thank you, Tony. We've got time for 2 more questions. So Jeremy here.
Jeremy Lawrence, freelance health writer, and I work with Gianluca at the Institute of Global Health Innovation. I just wondered what view the panel took of the safe childbirth checklist, born of the surgical checklist, which was launched 6 years ago in 2 areas of India, I think, and has since spread to 29 countries around the world. But so far as I'm aware, there are no results yet. At least I don't know them. I don't know whether you have any insight into the results or any hopes of what that might bring.
Okay. Question. I think the body language of the panel would suggest that they haven't yet seen any of the outcomes of that work, Jeremy. Which in itself is an issue, isn't it? Because we are therefore not learning from others' work as rapidly.
It's the journalist to catch everyone, right?
Very good question. So we will. Others in the room will carry on working to find out the answer to that question. Thank you. And there's a question in the front here. Oh, yes, thank you. Can we have the microphone over here? Thank you. Are there 2 questions? Okay, 2 last questions then. Thank you. I'm anxious that you get some lunch at some stage.
Thank you very much for the informative and yet comprehensive panel discussion. Dr. Karen Cummings, Minister within the Ministry of Public Health in Guyana, South America. I listened very attentively, and I'm wondering what suggestions you may have or what kind of maternity transformation programs you would advise in our setting there as policymakers. In fact, we have 5 tiers of healthcare in Guyana, starting from as low as the health posts, health centers, district, regional, and then the 1 tier, the tertiary care, level 5. And we try to narrow the gaps between the hinterland and the coastland, where they have the indigenous community. And so whilst we are working on telemedicine, to work on that and try to sending specialists, especially to the hinterland regions. But we're trying also to train community healthcare workers because of cultural barriers and so on. But in terms of sustaining the specialists going in there, it has its own problems. But we're having increasing costs in terms of Medivac in high-risk mothers and so forth. So I'm wondering, in those kind of settings, what would you advise in terms of maternity transformation programs? We didn't do so well in the MDGs 4 and 5, and we looking at SDG now, and so how can we be on the right path and come up to first world standard?
Thank you.
And secondly, for my friend there, could you expand a little more on the selective contracting?
Okay, thank you very much. So, Marina, would you like to
yes,
both of those
the
questions?
selective contracting, as I mentioned, we use this method of the selective contracting under the universal health coverage. We have that in the big cities, especially. We have the several service providers, so we are able to choose 1 or the 3 of them. Not in the rural areas or remote areas. We have the one one service providers, and we will not be able to exclude them from the universal health coverage. But there we use the quality indicators, and we monitor these indicators. That's we have the agreements with the medical institutions. We have the requirements. They are not satisfied this requirement, so they will not be the part of universal health coverage. As the UHC program is a main financial source for our medical institutions, so they are interested to be part of this program, and this is a powerful tool in our hands to use. So this is selective contracting that's famous tool in the world, and the Georgia is not the exclusion from the world. That because we started use it in the field of maternal and child health, and we want to expand this in the high technology services. For example, there's a cardiosurgery, neurosurgery, and then intensive care, and so on. And the second question was, for example,
transformation.
Yes. Despite the Georgia is a small country, we have that's not only the big cities, the big city in comparison with the India, and there's the other issue, but in Tbilisi we have that more than the 1.3 million population, yes. But we also have the high mountain regions, and the density there is very low. So there we have in 2 or 3 region we have the one medical institutions. The first level, there the pregnant women with that normal condition are able to apply. But if they have the complication, so we suggest them to apply to the second level medical institutions, which are located in the more bigger centers, more bigger cities, for example. And it's better to move when you are the pregnant than when you are in labor condition, and to move with your babies from one medical institutions, and to lose the gold minutes after the childbirth. So it's better approach.
Marina, I think yeah,
it's enough,
yeah,
I think.
I think so. Okay, thank you. Very important question. Maybe we can continue conversation afterwards. I'm anxious that we're getting our sort of close down signals. So one last question, and then we'll close. Thank you. Sorry, we'll come back to that.
Hi, I'm Anna. I'm a UK midwife. We talked specifically. You talked about escalating and recognising deteriorating babies and patients. Have we looked at the staff well-being? Because of when midwives and doctors are overworked and work very, very long hours, that's when mistakes are made, mostly when mistakes are made. So how much are we looking into that?
So thanks for that question. I think that's really important for me and certainly the programme I'm working with. There's always a need to make this work focused around the woman, the families and their babies, but we're very much making it person-centred, so it's about the staff that we work with as well. One of the easiest and best ways of doing that is by focusing on the welfare of the staff that you have, but also thinking about the cultural welfare of the staff that you have. So we've seen quite high levels of personal burnout in most people in the culture service that we've got, which is not unsurprising. But you see residual pride in the organisation as well, which means that people don't want to leave. They want to work there, but they know that they work over and above the hours that they normally would. So it's a case of how we can protect the workforce actively in the work that we're doing and focus some of the improvement work around that. IHI brought out a particularly good framework last year before last now, Joy in the Workplace, which has got some fantastic tools about how you can address some of that and measure them in real time, so that you can make a focus on ensuring everyone gets their breaks in an appropriate time. And if that involves leaders coming into the workplace on the delivery suite to relieve people, then that type of behaviour should be modelled and looked at. It's important to think about workforce, how we use our workforce. So rather than saying we need more people, how can we use the people that we've got more effectively? So some of the labour wards where I work, use volunteers to settle women into delivery rooms rather than using midwives, so that you're offloading some of the small areas of workforce to generate more people. So for me, it's absolutely critical, because actually if all we're doing is pushing our workforce harder and harder, because the complexity is going up, but not acknowledging. And we have a retirement issue coming up in England, as I'm sure you're aware, that a third of our midwives in the UK are over 50. So we're going to have a workforce gap, and we have huge rota gaps within the junior market within the UK as well.
Thanks, Tony. Thank you. I hope that helps. I mean, certainly for me, two throwaways is the importance of listening and supporting the second victim when anything goes wrong, and second or third victim is always the staff member that's been involved. And I think I'd ask you to think about the work of Albert Wu and Annegret Hanauer in that, looking at second victim and supporting communication there. The other piece is the Lucy and Leap Institute, who've just produced a fantastic blueprint for helping systems develop a cultural approach to the quality of care they offer. Lucy and Leap, and you'll see it on any good search engine. We'll throw that up. I'm conscious of the time here. I wonder if we could thank our panel for their contribution to this debate. I certainly, I'm sure they will want to thank you for your contribution as well. So thank you very much. Thank you.